All right, so welcome everybody. My name is Jennifer Surrett. I'm a lecturer with the Center for the Study of Human Health, and this is the second in our Race, Ethnicity, and Health speaker series. We are super lucky to have Dr. Shivani Patel, who is a social epidemiologist and Rollins assistant professor in the Hubert Department of Global Health. Her ongoing research focuses on cardiometabolic diseases, which are implicated in the severity of COVID-19. Her current work on COVID-19 includes the creation of the National Health Equity Dashboard and collaborating with the Georgia Department of Public Health to examine the impact of COVID-19 across communities in Georgia. She also leads the data generation and dissemination component of a Georgia-wide initiative to scale up COVID-19 testing among people with diabetes and at risk for diabetes. So a quick announcement, we're going to actually end at 5:15 instead of 5:30 today. If you have questions throughout, you can put them in the chat box and we can get to them throughout because we have a fairly small group. You can use the raised hand icon if that's available during the webinar, I'm not sure. Or if there's any leftover questions when Dr. Patel finishes her talk, then we'll be sure to address them at the end. Does that sound good? All right, thank you so much for being here, Dr. Patel. We really appreciate it.
Thank you for the invitation. And I'll just say that I also don't mind if folks unmute themselves. I'm not sure if they have that ability to unmute themselves and speak. That might be slightly easier because I notice it's very difficult for me to monitor the chat somehow when I'm in presentation mode. So first off, let me just confirm that you see my, well, actually, have I started sharing? I don't think I've started sharing. And then do you see the presentation mode?
I do. Yep, that's great.
Okay, wonderful. All right. Thank you so much for this invitation. As Jennifer just mentioned, I am an epidemiologist, and of course, for all of us, COVID-19 is a new area of research and practice. But for me, I also have in the past primarily focused on chronic diseases such as diabetes and cardiovascular disease. So the infectious disease space is pretty new, but I'll get into a little bit of why I'm bothering with this work as the presentation goes on. So today, I'm just going to give a really high-level overview of racial ethnic disparities in COVID-19, describe some of the drivers of the disparity, and then I want to talk about some of the work we're doing with the COVID-19 Health Equity Dashboard. Already as mentioned, I think with this sort of a group, I'm very comfortable with the conversational format, so please do feel free to unmute yourself and ask me questions or make comments along the way.
I don't think they can unmute, but if they put something in the chat box, then I will unmute myself.
Perfect.
Okay.
Perfect. Because the meeting controls go, and it's again, so that'd be great if you just unmuted, and I'll also try and pause for questions. So race has really been at the center of COVID-19 disparities and the conversation around COVID-19 disparities from the very, very early days. So these are some headlines I pulled just from the first week of April. So about a month into a solid month into the epidemic. And you can see, why are Black Americans at higher risk for coronavirus? How is coronavirus affecting Black Americans? It's a racial justice issue. Black Americans are dying in greater numbers from COVID-19. And of course, we've all been following the headlines this summer and through the fall. And it's even been described as a dual pandemic of COVID-19 and of racism that have come to a head in the nation. So it is not surprising to this audience that indeed, we see at an individual level that Black people are dying at 2.2 times the rate of white people. And this is work that's been put together by the COVID tracking project that's put out by The Atlantic. And I think it's one of the most valuable sources of data that we have on COVID-19 disparities. And one of the reasons why there's so few resources to track such data is because in the United States, as we all are hearing about, we don't have great surveillance systems. We don't have centralized surveillance systems. The surveillance or health in general, is the responsibility of the state, and the states basically defer a lot of that responsibility back to the counties. So I work actively with the Georgia Department of Public Health, and they themselves have some limited control over certain data points and also data quality, because they are also at the mercy of county health departments, which are, of course, suffer from underinvestment and being stretched very thin at the time of this pandemic. So what projects like the COVID tracking projects do is look at the publicly available data and aggregate it for end users, such as my group, such as the New York Times and other places. And it's one of the places, like I said, that bothers to do this by race and ethnicity. A second thing I want to mention with respect to race and ethnicity specifically is that we track disparities by race and ethnicity for COVID and because it's the one sort of social indicator that we manage to capture through routine public health surveillance and patient care. So we don't in the United States ask about education or occupation of the people who are getting tested or the people who are getting treated for any condition. Race and ethnicity are basically the only variables we have to sort of understand some of the social patterns of disease. In this case with COVID-19, we see that looking at the pattern of death by race is actually really informative, as you see in this curve or this bar plot. And this bar plot already gives you an indication, but I want to go to the CDC data that does this just at a national level and reports this as a national level, and really hits home the fact that it's not just Black Americans and it's not just death. So we can also look at cases, we can also look at hospitalizations, and we see that virtually all racial and ethnic groups that are non-white have a higher rate of becoming a case, of becoming hospitalized, or of death. And the big exception is that Asian non-Hispanic persons don't have an increased risk of death compared to their white peers, at least white non-Hispanics. And they also, of all the groups, have lower excess risk of becoming a case or becoming hospitalized. But you can see from this figure in particular, and some of the patterns don't necessarily hold across the board, but what we'll see is that the risk of hospitalization, which is a measure of severe outcomes, is especially higher in all of these race ethnic minority groups, and the risk of death is also higher. Going back to the data capture, as an epidemiologist, I feel that I need to warn you about all of the data issues. There's a lot of missing data in how we identify cases, especially. There's less missing data when it comes to race in the hospitalized individuals and the people who died. And for that reason, we oftentimes rely on the death data. The other thing being that death is a very hard endpoint, and our assumption is that if someone has died of COVID-19, there's a pretty good chance that we would have ascertained that death. Whereas if somebody became a case, somebody acquired the infection, but for whatever reason was not tested, perhaps some people have deemed themselves presumed positive. We might be severely undercounting some of the cases. So these are some of the things that you should be thinking about when you look at data regarding race and ethnic disparities in COVID-19. But in addition to looking at these individual rate ratios, we can also look at COVID-19 by race at a community level. So what this figure shows is the percent of each county that is African American in the United States. And the darker shading reflects counties with a higher proportion of African Americans. And it's an ecological analysis. So what we did was divide those counties into groups of 5 or quintiles. And on the right-hand side, we plotted the cases per 100,000 and the deaths per 100,000 in each group of counties defined by the proportion of African Americans. So what we see here is that in general, there is a tendency for their counties with the highest proportion of African Americans to also have the highest average COVID-19 case rates per 100,000. And while that sort of there is a pattern, and the lowest quintile sort of defies that pattern a little bit or breaks from that pattern a little bit, it is quite a pronounced pattern. But when you look at the deaths, you see that this pattern is even more pronounced, and especially in counties with the highest concentration of African Americans, you see a much, much higher, twice, to over twice the death rates that we see in the counties with the lowest proportion of African Americans. So this is an ecological analysis, and one of the concerns that we have with ecological analyses is that it's difficult to disentangle multiple things that might be happening at an area level. And I am using the term county level concentrated disadvantage to describe some of what we might be seeing in those African American counties. And the idea here is that it's not just about the racial composition of a county, but it also happens to be that the same counties that have a high concentration of African Americans also have a tendency towards more vulnerability, as defined by this Community Vulnerability Index, which is a measure of over 30 characteristics measured at the census level on factors that are expected to relate to COVID-19 infection and death. When we look at diabetes, you also see this general pattern of a concentration, or rather a visual correlation between the proportion of each county that has diabetes and the proportion of each county that's African American. And again, with poverty, you see a lot of overlap. And for anyone who has looked at a map or considered these sorts of county level analyses, you would have picked up on the fact that a lot of this is concentrated in the southeastern United States. So a lot of my work in county level health determinants came into being when I joined Emory as a postdoctoral fellow. And we were originally working at the state level, looking at cardiovascular disease, mortality disparities across states. And we saw that, we really need to go one level below to the counties. And moreover, it became clear that it didn't matter what health outcome we were looking at, the Southeast appears to have a disadvantage. And to what extent is that disadvantage racially mediated or socioeconomically mediated is an area of research and concern. So one of the other significant pieces of this, this concentrated disadvantage in the southeastern United States is that we have historical insight on this issue, and we also have some quantitative data suggesting that a lot of this is likely the legacy of slavery and Jim Crow, resulting in a political and social environment that is not conducive or favorable to health, and especially not conducive or favorable to the health of African Americans. I also, though, must show you this figure, which shows COVID-19 by the residential segregation index. So higher values of the residential segregation index indicate, as it would imply, a higher degree of residential segregation. By residential segregation, I'm referring to the process of similar race groups residing with one another versus dissimilar race groups residing with one another. And so in the United States, again, through various economic and political factors and policies, we have a situation where most of the country is highly racially segregated when it comes to housing, and you see this within counties and also across counties. But when we look at this picture across counties, you see that there's a reverse association between residential segregation, something that we've historically thought of as a bad thing for especially the health of minorities. So we see a flipped association between residential segregation and COVID-19 cases and deaths as compared to what we saw with the proportion African American. And part of that might be that actually in the US South, likely because of the high numbers of African Americans, you actually see more residential mixing than one might expect. So then you have, again, to think about, residential segregation in isolation versus residential segregation maybe being confounded by some of these other factors. Again, at an ecological level, it might be really difficult to disentangle this, but I just want to highlight some of the complexities in considering race and ethnicity and health outcomes. I see that I've posed the question why, but I kind of answered the question why. But I'll pause here and just see if there are any questions or comments on this particular map of residential segregation or anything else I've said so far. I don't see anything's popping into the chat, so I'll just keep going. Another dimension of the race ethnic disparities with COVID-19 that are important to remember is that these disparities are not fixed over time. So in contrast to a lot of the health conditions we study every day, such as the diabetes, cardiovascular disease, cancers, there might be some fluctuations, but it's not a month-by-month fluctuation the way that we see with COVID-19. COVID-19 is a very, very dynamically moving epidemic, whereas chronic diseases and even infectious diseases like HIV, we don't expect them we don't expect the numbers to change so dramatically. And yes, we do track over time, we track on a daily basis, but the entire picture for COVID-19 as an epidemic condition changes from month to month. So I wanted to highlight this point right here. So this is a MMWR piece that was done by authors who are using federal data. And, they conclude that, from May to August, the percentage of descendants who are white decreased from 56% to 51%, and the percentage who are Black decreased from 20% to 17%. Whereas the percentage who are Hispanic increased from 16% to 26%. Now, I'm not sure if you can actually see the legend, so I'm going to just talk it out for you a second. So the black bars are non-Hispanic white patients, and the blue bars, the first blue bar are Hispanic patients, and the second blue bar are Black patients. And I won't get into the Asians or American Indian populations or others, just for the sake of simplicity right now. But you can see that in general, at the beginning of the epidemic, we see that whites had contributed to a greater share of the deaths, but since the beginning of the epidemic, their share has generally gone down. And again, there's been a little bit of an uptick more recently. And then the second piece being that with African Americans as well, their share has generally gone down, whereas generally the Hispanic share has gone up. Now, you can see though that again, this isn't a neat pattern, a neat, clean, linear pattern that's monotonic. We also see some changes with, for example, Hispanics potentially dipping again, and also Blacks potentially dipping again, and whites rising. I mean, I'm bringing home some of these points, or what I'm hoping to convey here is that when you look at data for COVID-19, it's really important to ask, what time of the epidemic are we talking about? Is this before the peak of the first peak, or is this after all the peaks, or, or as the cases are peaking, et cetera? And the second thing that I want to highlight is this figure shows it a bit, and there are other figures that would show it a little more nicely, that we see a tendency for this disparity, the racial ethnic disparity in COVID-19 to increase over time. And the hypothesis is that it's because white Americans were in a better position to socially distance and basically adhere to precautions to avoid infection, whereas it was much more difficult for some racial and ethnic minority groups, especially those engaged in essential occupations, to socially distance. And that might be one of the reasons that we see this pattern. I did see that there was a question, and I'm going to see if I can find it. So there's a question from Suzanne Martin on whether my work and research explore why counties and neighborhoods are segregated and the effects of such segregation. So I don't directly work on residential segregation, but I do know that there are people who work very explicitly on residential segregation. One of the reasons why they work on residential segregation, rather than say the percent of the county that's African American or the percent of the county that's minority, is because residential segregation is seen as something that is potentially amenable to policy and might be more modifiable, and or rather that might be the preceding mechanism to some of the disparities that we see through concentrated disadvantage. Ali Sewall in the Department of Sociology, I believe, does look at segregation as one of the factors. I think she may not look at this at the county level, but at lower levels of geography, such as census tracts and that sort of thing. I'll also say that, again, what I showed you might be a factor of the level of geography, because we were talking about counties. If we went below the county level, we might have seen a different picture, in that we might have found that within the state of Georgia or within the metropolitan Atlanta area, there were more residential segregation was associated with higher rates of COVID. I don't have the data to support that. One of the reasons I don't is because we don't collect data at that level. I can actually get it through DPH. I haven't looked at it, but the publicly available data really only goes up to the county level. So I hope that answers your question, and happy to discuss more on that towards the end.
Shivani, I have a question.
Uh-huh.
This graph that's up here now, I mean, I had no idea about this. Do you think this relates to, what is called the Hispanic paradox? Or how does, because, the idea that the Hispanic populations have similar socioeconomic status to Black Americans, but seem to have better health outcomes?
Yeah, so I think that, so this particular graph, I think, is actually showing that across the particular health system surveyed, this is the National Vital Statistics System. So across the states included here, Hispanics actually had a higher, contributed to a higher share of deaths than Black Americans. So it would kind of go counter, I think, this particular piece of data. However, we are finding some evidence of that in our analyses of the Georgia Department of Public Health data. We see that Hispanics are more likely to be hospitalized, but they're less likely to experience death once hospitalized. We think that they're more likely to be hospitalized because of occupational exposures and infection and potentially delayed healthcare. And not potentially not having access to healthcare, but for being hospitalized. But once hospitalized in Georgia, what we're seeing is that they have lower risk of death. So that could be an opportunity for kind of thinking about COVID through the lens of the Hispanic paradox.
That's super interesting. Thank you.
And actually, speaking of not paradoxes, but thinking a little bit more deeply about different race ethnic groups and thinking about how this might vary by state. So one point I wanted to hit home was that this changes over time, and a second point is that this changes by geography and state. These are data, so we're drawing from the COVID tracking project again. Here, instead of showing the share of cases that were white or the share of cases that were Asian or Black or Hispanic, what we've done is actually compute rates per population. And I think for a variety of reasons, this is a sounder approach from an epidemiologic perspective to do comparisons, right? Because we always want to understand who's the proportion at risk, or we need to sort of take into consideration the proportion at risk before we talk about absolute risks and that sort of thing. I think one of the reasons we don't see too much of that is we don't have a clear denominator for COVID-19 or for anything in this country from our surveillance systems. So that requires a little bit of coupling data that not everyone is comfortable coupling, because you have to take cases from a surveillance system and you have to take denominators from survey systems and census and that sort of thing. And then the other reason being, we actually have a lot of missing data for cases, and then the rates end up making no sense for various reasons. I won't get into the details of the missing data stuff much more than what I've just said, unless people are interested. Anyway, what we see here is if we look at deaths by race and ethnicity, African Americans stand out in the state of Georgia, but Hispanics don't, not for deaths, and neither do Asians. And you know, we're maybe not so surprised when we think about Asians in Georgia. It's a higher SES group. Hispanics is maybe a little bit surprising. And this is not a formal analysis, but one thing I was noting is that, you know, as far as minority populations go, the African American population in Georgia exceeds the national average, whereas the Hispanic Latino population is lower than the national average in the state of Georgia, as is the Native American population. So that's what you see on the right-hand side of these comparisons of Georgia to the USA with respect to some of these demographic characteristics. So that's Georgia, but how does this compare? And you might be also wondering, you know, like you've been reading about all of the deaths in the Southwest and Native communities. And again, this is why I really want to emphasize the point that we have to look at it state by state and probably think about exactly who are the, you know, we are so much more than just our racial ethnic background. And also communities have sort of come into being and have settled in different places under different circumstances. So kind of taking all of that into account, I think we can interpret, or we can begin to interpret some of the differences here. So for Texas, you see that it's the differences between African Americans and whites in terms of deaths is not, there is a higher rate of death in African Americans compared to whites, but it's not the same level of excess death as we saw in Georgia. But we see a huge excess death rate in Hispanics as compared to whites in Texas. And if you look at the share of Texas's population that is Hispanic, you see that that far exceeds the national average, whereas with African Americans, it's about the same as the national average. And then with Native Americans, you have kind of a very small minority, and that share is much lower than the US average. And then we go to Arizona. And in Arizona, I mean, and this is one of the, you know, I think one of the saddest stories that we see, because you can just see that the excess rate of death in Native Americans is just beyond belief, and it's unconscionable. And of course, excess death of any kind is a public health problem. But when you see the magnitude of that disparity compared to, say, the disparity that we see in African Americans or Hispanics in other settings, it's just really alarming. And you can imagine a lot of stories around that. And again, here, what I found to be a little bit interesting is that, of course, the Native American community, or the Native American share of the Arizona population, far exceeds the US. I don't have like a full analysis on this, but I'm just thinking about, you know, so kind of linking this to the Hispanic paradox idea. So one of the ideas behind, or, you know, one of the hypotheses to explain the observed paradox is that it could be a healthy migrant effect, right? So I just wonder if some of what we're seeing here is that the larger minority groups have a longer standing presence in each one of these places, whereas some of the smaller minority groups might be not necessarily migrants, but just might be a little bit different than those larger, long-standing minority groups in each one of these settings. But I think this is something sort of worth exploring. And I'm not a scholar of race, and I'm not a sociologist. I'm an epidemiologist, but I think the descriptive data are really interesting and informative. And then again, the main thing I'm trying to hit home is we can't just look at the national data. We really have to go past the national data to look at and understand what's happening in each state separately. And so this brings me to sort of the second phase of my remarks today. Why do we see these disparities so consistently? And so I operate from this social ecological model of disease causation. And this model posits that individual and population level health is a result of pathophysiological factors and genetic factors that are impacted by individual risk factors, social relationships, and living conditions that are all embedded within neighborhood and communities, institutional environments, and social and economic policies. And I kind of put arrows on some of the ones that I think are most critical, but you can imagine for COVID, each one of these is extremely important, and we can't understand really what's happening. I think even at a risk factor level, if we don't really think about that broader context. And so I've highlighted some of the factors, using that paradigm that I think could be important for COVID-19 specifically. So for example, the social and political structures that I've already alluded to are sort of slavery and migration histories, as well as overt policies of exclusion. Some of the healthcare factors include healthcare access, utilization, quality, living and working conditions, so the occupational risks, the housing, the interpersonal discrimination that minority communities and especially African Americans have experienced, say in Georgia and in the US South. Socioeconomic status, including educational attainment and income and wealth, and these tend to both be lower in most racial and ethnic minority groups in the United States, with the exception of Asians, at least in comparison with white Americans. And then finally, health risk factors. So the higher risk of obesity, diabetes, and cardiovascular diseases in minority groups. And as you know, these are also risk factors for poor outcomes. So I'm going to just give a very quick example of each one of these. So this is a map that I think is just fascinating, and it comes from 1938. It's a map of Atlanta that shows redlined areas. And basically, these redlined areas were ones where there were lending practices that were designed to basically exclude people from loans that were deemed to be high risk. And those areas of high risk were really defined by Black race. So this is a very old map of Atlanta, and superimposed on this older map of Atlanta is the location of food outlets that are available to SNAP beneficiaries, so SNAP retailers. And the food outlets come from 2017. And so the thing to look at here is that the superstore or the supermarket, so the kinds of places that most of us would want to buy at grocery stores, the kinds of places that would have fresh vegetables and that sort of thing, are those yellow dots. And I'm not sure how visible it is on your screen, but if you were to examine this map, you'd see that most of those grocery stores exist outside of the redlined areas. So there are very few. There's like one in this area where, okay, hopefully you can see my mouse. There's one in this area, and there are a couple that are adjacent to this redlined area. But within the redlined areas, even to this day, they don't have grocery stores. And instead, you see many convenience stores, which would have, of course, foods that are not as healthy and are generally believed to promote chronic disease risk and cardiometabolic disease risk. So we're talking about packaged foods, and non-perishable sorts of, or rather less perishable sorts of food items. I thought this was a really powerful quote by the author of the blog where I found this, that, supermarket redlining then is, as a term, resists framing disparities in access to healthy foods as just a side effect of an otherwise functional market or some natural urban ecology, as a bug in the system, so to speak. Rather, it highlights how the locational decisions of food retailers are evidence of intentional disinvestment in low-income neighborhoods and communities of color. And again, I just think this is such a powerful graphic to show how these historical factors, these economic and political factors, still play into the health of Americans today, and especially minorities and Black Americans today. The second example I wanted to give was on healthcare, and I didn't pull a bunch of data on disproportionate access to healthcare, because as students and researchers and faculty members working in human health, I imagine you're all very well versed in those data. But what I thought was an interesting piece of data to share here is that when we look among people who've been hospitalized for COVID-19, we actually don't see an excess risk of death. So, that could be interpreted in maybe many ways. So what this plot is showing, or this table is showing, let me first walk you through that, is that in reference to whites who had been hospitalized across 92 hospitals in the United States, Black patients were 0.86 times less likely to die in the unadjusted models. And that was actually a significant result, statistically significant result. Once we account for comorbidities and other factors, those results become non-significant, but it is still, so basically it's an statistically indistinguishable risk of death from whites, but it still trends to be a little bit lower. And then when we look at other people who identified as other, we also see a lower risk of death. And what I think is interesting is the interpretation by Dr. Boulware, who suggests that it's really telling us that the solutions lie in policy, but not biology. It's not something about the biology of Black people that is leading to excess risk, but it is precisely access to healthcare, because once we select on healthcare, we make everyone even on healthcare, then we don't see this excess risk. I'm also showing this piece of data because we've seen this in our Georgia Department of Public Health data as well. So that is no longer drawing from, well, it ultimately has to come from some healthcare system somewhere, but it's not a repository of an electronic healthcare record or something like that. Rather, it is the electronic laboratory reporting system that all hospitals have to use because COVID-19 is a mandatory reportable condition. So when we look at all cases and hospitalizations and deaths in Georgia, once we select on hospitalizations and we do this sort of a time to event survival analysis, we no longer see that risk of death. I also, though, will caution everybody that it really depends on what point in time, because we think that some of this effect is because we're getting better at treating COVID-19, and that if we had cut the data at earlier in the epidemic, we would have seen larger race and ethnic disparities. But I think just some really interesting work, I'm told, across Emory Healthcare, they're also generally finding the same pattern, that once hospitalized, we don't see this excess risk. I've also mentioned living and working conditions, and we've heard a lot in the news about essential occupations and the ability to isolate forgetting isolation. Before we get to isolation, just the ability to socially distance and maintain socially distance. So, the data here aren't great. I actually have a student working with me on getting better data and trying to put some national numbers on this. But this is one example of a paper that looked at employment and essential occupations by race. and found that people who are employed in essential industries were, and therefore more likely to be exposed to COVID-19, tended to be non-white. And you can see some of these numbers here. So, and these are all estimates. So they're based on labor statistics broken down by race from 2019. So we have to go by older data, right? Because we're not collecting a lot of these data right now because of the pandemic. So if we take people who are likely employed in an essential industry, it's 27% of whites would fall into that category, 37 or 38% of Blacks or African Americans, 26% of Asians, and 27% of Hispanics. But if you look at a few other ones, like I think it's not cut off, or it's not included here. If, for example, bus drivers, African Americans were much more likely, and also Hispanics were more likely to be employed as bus drivers, and of course that's a job with a lot of risk. And then we know that Hispanics in this country also are engaged with the informal economy, so they might not show up in these measures. But if you walked anywhere in Atlanta this summer, one business that was not shut down was construction and landscaping, and most of the people, at least in the part of Atlanta I live in, who are engaged in this section, in that type of work, happen to be Latino. So that is, absolutely an occupational risk that I think was driving these surges in hospitalizations in the Latino community that we saw, especially towards the end of the summer. And then my penultimate example on the health bit is diabetes. And we can think about, the intersection of diabetes, COVID-19, and race. These are actually not US data, because I think the UK data are just so much more powerful, since they're able to draw on the entire population. So this is the National Health Service data from England. And you see that in this figure that it doesn't matter what age group you're in, this blue line is the deaths per 100,000 people among people with diabetes, type 2 diabetes. I'm focused on type 2 diabetes because that's a larger group, and it's also a condition that disproportionately affects minorities. So that darker blue group always has a higher rate of death than the overall population, which is this lighter blue or turquoise line. And also, if you compare specifically the people who have no diabetes, which is the purple line, you also happen to see this, very pronounced difference in deaths per 100,000 people. And these are COVID-19 deaths per 100,000 people. This was a working paper that I saw come out really early on, and then it looks like it was just published officially or came out in print just last month. But I want to say it just came out a few days after this May 11th cutoff that describes their data. On the right-hand side, the authors go on to show the odds ratio for death in adjusted models. And also, so this is the odds ratio for hospital deaths for people with COVID-19. And it is by demographic status and diabetes status. So basically, once we account for diabetes even, we still see that Blacks in England also, and Asians in this case, have a higher risk for death than the whites who were the reference group. In the United States, if we were sort of to extrapolate some of that information in the United States, we know that each racial and ethnic minority group in the United States has a higher level of diabetes, higher prevalence of diabetes than do non-Hispanic whites. So we see this across gender, and again, this is after adjusting for age as well. So when you combine those two pieces of data, that there is a higher risk of death associated with diabetes, and there's a higher risk of diabetes in race ethnic groups, that's been cited again and again as one of the reasons for the excess risk. But I think that even that comorbidity risk, really needs to be understood in light of the social determinants of health. So some of the structural factors I mentioned, and that's why I brought up the food environment specifically. But also we can think about, so we've talked a little bit about structural discrimination, but also the idea of interpersonal discrimination and how it physiologically might be getting under the skin, reduce some of these comorbidities. So this is sort of, these are all the slides are teasers. I don't have enough time to go very deep with any of these, but there are, stress hypotheses kind of suggesting how environmental stressors will trigger a perception of stress and will lead to direct physiological responses as well as behavioral responses that then further exacerbate a physiological response that is bad for health. And we think of the accumulation of all of these stressors as allostatic load. What I've provided here, just a couple of references. One is by my colleague Tanae Lewis in the Department of Epidemiology, who's a psychologist who studies the impact of racial discrimination on health. And so one example is this chronic exposure to everyday discrimination and coronary artery calcification in African-American women. And coronary artery calcification is a measure of atherosclerosis that can be an early measure of risk. And then another review on the empirical research on self-reported racism in health. So, I again don't have time to link up all of the boxes, but these are, I think, some of the leading explanations for why we see excess risk of death and poor outcomes in African Americans, especially. And now this leads me to the last part of this presentation, what my group is doing about these disparities. And it's less about what we're doing and more, I guess, about what we're saying and how we're trying to interact with the space. So we have developed the COVID-19 Health Equity Interactive Dashboard. You've already seen some links to it, but it's available at covid19.emory.edu. And the motivation behind the dashboard was to really consolidate and synthesize localized data on COVID outcomes and put them in context at a county level, because we really wanted to connect the data to the national and local narrative for ultimate action. And when we were surveying the kinds of work that was happening in COVID-19 early on, we felt like the health equity piece was one thing that was really missing, and that was one thing we wanted to inject into the space. So we saw a lot of great sites like, the Johns Hopkins site, New York Times, and at that time they were really focused just on showing the case rates and the death rates and have done a marvelous job with that. But we also wanted to really bring front and center the issue of health equity and broader contextual characteristics at the county level. Our audience was policymakers, the general public, academics, and media. So basically anyone and everyone. And that hasn't really changed. I think we still keep trying to pitch it to everybody. So some of the dashboard features include, so we have a landing page that has this interactive visualization that we've actually changed up just a little bit. There's a state summary. There's an interactive map to select county data and also hover over different counties to do the comparisons. So you've already seen a lot of screenshots from the dashboard in this presentation. There's a county page with detailed county data. We also have a media hub and an interactive state mapping page. And the ultimate goal is we want users to be able to go to the dashboard and say, find out how is their county doing, how vulnerable is their county to COVID-19 impacts, and how do the social determinants of health relate, and how are different race ethnic groups experiencing the pandemic in one's county. We also show some data on test positivity. So, the reason why we added the multimedia podcast series and videos and that sort of thing was we realized just putting the data out there wasn't sufficient, that a lot of people wanted to be walked through the data. And it just becomes a more cohesive narrative when we do that. And then part of that also led us to an interesting partnership with today, where we have.
Oh no, you froze.
With what is going on with that. Oh, did I freeze or did the presentation freeze?
You froze, but right after I said, oh no, you froze, you came back.
Okay, so how long was I frozen?
I think if you, just a few seconds, I think maybe if you start back again with not this slide, the next slide.
Oh, great.
Yeah,
I
right.
I didn't really even say anything yet, so that's great. So, so we had this interesting partnership. So it started off as just a media request where a USA Today reporter wanted to talk about college football, and then I was like, I think we have some data to look at this. And then a master's student, Pooja Nayak, really took it on to not just compute the data, but create a way to dynamically update the data. So what do cases and deaths look like in counties with Power 5 colleges versus counties without those Power 5 colleges? And so we're always looking for opportunities like this to make the data a little bit useful. And it ends up guiding a bit of the decision making. I mean, so we know all these decisions have people have gone back on them, and then I actually haven't followed where this particular decision is, but our goal is to our best of our ability link it up to these sorts of people who need data to make decisions. And as part of that, we've also partnered with the Georgia Department of Public Health. I've mentioned that a couple of times. So in addition to the analyses we're doing with them on health equity, we've also created a dashboard for Georgia specifically. And it shows graphics like the ones I've shown you earlier, but just focused on Georgia alone, and also uses the Persons Under Investigation database in Georgia. We're doing our best to disseminate it across different channels like the CDC and professional meetings and settings such as this. And I went through that really rapidly because I'm just looking at the time and I want to make sure there's sufficient time for questions, and happy to take them. But I'm told that many of the attendees might be students. So really wanted to highlight some of the issues. So I've touched on the fact that this is a really dynamic space, dynamic outcomes and exposures, and that makes for an exciting working environment, but also a very challenging one, because there's constantly an evolving knowledge base, evolving interventions, and the policy environment keeps changing. So we hardly have time to vet what we've done before we have to move on to the next thing. And that doesn't necessarily feel comfortable as a scientist at all times, but it's also sort of the need of the hour. We're not able to always get the individual level. That's why we went to that county level unit of analysis very quickly, because we were able to look at more characteristics, more contextual characteristics, if we put it in that county framework rather than an individual based one, because like I said, there's no other variable collected on individuals. We just have race. Sometimes we have age. Lot of problems with the data capture, aggregation, analysis, and I've touched on some of that. We get the data from these higher levels, these folks who are aggregating the data, but that data comes from the bottom up, and there are a lot of irregularities. There's a lot of missing data with race and ethnicity, and so that makes it very difficult to track what is happening. We also have problems with small area estimations, so small counties where the population denominator might be unstable. And then of course, communication with the media and lay public. So anyone who's following, the Atlanta Journal-Constitution sees that, the DPH has really come under fire for some of their data decisions. And more recently, it's come out that, it's clear that they weren't necessarily DPH's data decisions to begin with. But all of these, when we talk about data for real world applications, it's like a whole host of things that we're not necessarily trained to do when we're in school, but I think it makes the work even more important. And so I wanted to conclude with some thoughts for public health professionals and researchers, such as you all are. I don't know if you consider yourself that, or I imagine you're at least in partial training, potentially interested in that path. And I want to say that, descriptive epidemiology is valuable. I I guess at this level, you might not have seen a big distinction between descriptive versus analytic epidemiology, analytic epidemiology being the kind that tries to isolate causes. But there is a big divide in the field, and there's a lot of emphasis and sort of like a higher social status placed on the analytic epidemiology. But a lot of what I've shown you today and a lot of what we know about COVID really comes from descriptive epidemiology, and I think we can't ignore its role. I would say don't wait for an invitation to the party. So, what I saw early on is that the media was doing a better job than many public health researchers were. And a lot of us as researchers, as academics, we oftentimes want to be very cautious and say, well, that's not exactly the area of my work. And I think, to each her own. But in times of public health crises, I think if you have an idea, if you have an interest, it's really important to just jump in, find opportunities, look for opportunities. I think, I'm calling this the primacy of action and utility must be situated within the complexity of today's public health context. And what I mean by that is there's so much emphasis on action, data for action. I've also used that terminology and invoked that a few times in this talk, but we also have to accept that not all decisions are data driven. And that's something I've learned through my work with some of our state collaborators, and changing the conversation might be all we can do. So we might, changing that conversation in the public's eye, or even in the academic discourse, might not have immediate results, but I think it's also just a critical part of what we might do. Don't let the perfect be the enemy of the good. Again, my way of saying, even if there are problems with the data quality and all of that, acknowledge it, transparently convey that. But I think that in the middle of a crisis, we can't wait around for things to be perfect. And finally, I really advocate for empathy and humility in data science. So I think that there's a tendency for cancel culture, not just in data science, it's all around us. And I think this cancel culture is part of why we have so much public mistrust of science. And one of the reasons why we're really struggling right now to get people to do the right thing, like wear masks. And so I would hope that all of us who are trained in science and in health really think about that. And before we retweet or repost or, any of the name calling that's happening, we think about, was a data error really made? Was it really malicious in nature, or those sorts of things before we go too far and jump on that bandwagon. So I've also included some resources here for you. I don't know if these slides will be posted or not, but feel free to contact me and I can also send these to you. And of course, I must acknowledge the team that I work with, which is fantastic and has come together exclusively over Zoom. I haven't met most of these people in person ever, at least the students that you see in the left-hand corner. And also, I'd like to acknowledge funding from our various partners. And with that, happy to take some questions and any comments.
That was so fantastic and expansive, and I really loved the messages at the end. So attendees, please put your questions and comments, we got to thank you very much, in the chat box, and we can get to them. But as they're typing, I mean, I wrote down enough questions to get us through another couple hours. But there's one question that's really burning my head, and I'm going to take the privilege of being the moderator to go ahead and ask. I remember the conversation recently about COVID deaths and comorbid conditions, and how are we classifying those? And the rhetoric of, well, that's not COVID, that's because there was diabetes, and and racializing that conversation. And so I think that it gets at a really interesting point, which is how are we defining a COVID related death, particularly when we know there are always high risk groups. So can you talk about the definition of a COVID, because even thinking about the COVID cases where there's like long-term health effects, You know, I'm thinking about how the difficulties of defining things like maternal morbidity and how much
Yeah.
longer after death, you know. So can you talk a little bit about that?
Yeah, sure. And that's a really good question. I don't have, um, I've been following this issue a bit here, of course, because of the work I do, but also in India. And in India, I'm told there's strict instructions that if there's any other comorbidity, you record the other comorbidity as the cause of death. And that's one of the reasons I'm told, through the grapevine, that's one of the reasons or the ways in which India's kept the death count relatively low, I'm told. Um, in the United States, it's highly subjective. So my understanding of the process, well, first of all, you have a physician declaring the cause of death and talking to physicians socially, not professionally as well, but even socially asking them these questions. A lot of them will say, it's so hard. We're not actually trained in this. We have to list something. And they ask for a primary cause and then secondary causes and that sort of thing. And then it's like, they have to list caused by what. So what was the triggering, what were the underlying precipitating events, sort of thing. So the one thing is that it's just there can be some subjectivity that way, but my understanding is that for better or for worse, there are also going to be instructions. So at some point, I know Fauci was saying that if anything looks like COVID, we're going to call it a COVID death. Done. And that was really in the earliest days of the pandemic, and some of the instructions given in New York. So that might lead to one kind of misclassification. And then if we're sitting in a red state or historically red state, where there was a different orientation around COVID-19 and eagerness to, I would say, minimize the burden of the pandemic, there may have been broader, even like within a hospital system, a culture of kind of shifting the causes here or there. But what happens for us when we analyze the data in terms of the actual definition, it has to be a death with a confirmed positive COVID-19 test, and the cause of death must be COVID-19, and it must be reported that way to DPH. Now, the cause of, or rather the deaths themselves, DPH combs the death registers to go back and link up deaths with the patients, or the persons under investigation in their list. And so that's how those systems come together. It's not very clean. So there's a persons under investigation database that's generated from the testing. It starts at the point of testing. Then you get all of the people who've tested positive. You ask more questions of those people through contact tracing. And with hospitalizations, we only know about hospitalizations if the hospital reports it, but deaths is something that are actively surveilled. But how those deaths get coded, really good question. And I imagine there's going to be a lot of regional and maybe even hospital-based variability in that.
It's really interesting. Thinking about moving forward, I mean, I think moving forward when thinking about the development of a vaccine, and then, you know, it's not just going to end with the development of the vaccine. Then there's all these things to figure out in terms of distributing the vaccine.
Absolutely.
Do you think that the type of work you're doing that's highlighting all these disparities in COVID cases is going to be integrated into this dissemination plan so that the disparities are not mapped exactly onto distribution of the vaccine?
Yeah, absolutely. So we approach it from a slightly different perspective in that we are not direct actors. Like, I make no pretense of being someone who is driving response, but rather generating data that might inform the response. So we're very much interested in this. And I have colleagues who for some time have been like, we need to get on this. And we have been in our own way. So if you look at the vaccine priority schedule, it's really based on the occupation. Right. So what we've started doing is looking at the proportion of each county population that falls into an essential occupation, and also trying to break it down by other factors. Then at the national level, where we have survey data through, for example, the National Health Interviews Survey, one of the projects a student is doing for his thesis, which I think is really cool, is looking at, identifying who would be in phase 1A, phase 1B, and what is the race ethnic distribution and kind of the socioeconomic distribution of those groups. And to me, there's an important sort of policy directive then of engaging those demographics, engaging those groups, and breaking down some of the vaccine hesitancy that we see. I mean, among our Emory students, I don't know what people on this call feel, but I've asked my students who are Masters of Public Health students, and it almost seems like at least 50% are not interested in the vaccine. They're saying that they'll wait it out because they don't have trust in the system right now. So if that's among people who are in public health, just imagine the general public.
Yeah, that vaccine hesitancy is really fascinating. Are there any questions from the attendees? And again, I have more. Well, why don't I just, I'll give you one final question, and then if there's any other attendee, oh, there is a Q&A box. I hope okay. Can you explain this, again, the significance of looking at hospitalization rates and death rates together? Is being hospitalized seen as a positive thing because it's a form of care that is not equally distributed to ethnic minorities? This is interesting to me because I've seen rates of greater hospitalization being presented in a negative light for being an indicator of overtreatment, bringing in insurance and Medicare into the conversation.
Yeah, that's a fantastic question, and I think raises a couple of important points. So first, hospitalization is seen overall as a negative thing, not because of overtreatment. It's seen as a negative outcome because it indicates COVID severity. So a lot of people, most people don't have to be hospitalized for COVID-19, thank goodness. And that's why we haven't had a repeat of the New York situation in Georgia or in any other place. We haven't had a repeat of Italy in most of the country, and that's because most people don't have to be hospitalized. So when someone is hospitalized for COVID-19, that's an indication that something isn't, that this is, because then that person becomes at risk for death, and it's already an indication that that person might experience long-term sequelae. So as an outcome, we treat hospitalization as an adverse outcome. However, in the analyses that I was showing you and I was sort of getting excited about with the death and hospitalization, that is, once we select on the people who are hospitalized, so we're no longer thinking about that as the outcome, but we're looking at the pool of patients who have been hospitalized. And then we look at death in those people. The relevance there is it's sort of like adjusting for disease, not just disease severity, but it's also adjusting for access potentially, because those are the people who made it to the healthcare system. There are also other interpretations. We've been struggling with this, and we actually thought that there was an error in our analyses for a really long time, or we really wanted to probe why we weren't seeing excess risk of death among the hospitalized. But now that we're seeing this in like place after place after place, to us, it's a little bit reassuring. It means that if people are given this, the same healthcare, we see that African Americans don't any longer experience that excess risk of death once they have COVID. So I hope that answers the question.
I think it does for me. I think it's great. I think you're right that it can be seen as a positive. I think it's a really great spin on it. My final question for you, in the interest of time, it's a short one, but I think it'd be interesting to know sort of the composite of your team. What types of are they all epidemiologists, or, I saw Ali Sewell on there, who's a sociologist.
Yeah, so Ali is part of the Georgia Department of Public Health work, and it's where we started really was this national dashboard, and that was it was a group of some clinicians, some epidemiologists, and actually was built by a computer scientist. And so we actually work with, I work more with people in the college right now than I ever have because of the computer science connection and the data science connection. So of the people that you see, I think very few are public health. We have like a couple of high school students in there, one biostats student, one global health student, and then the rest are either computer science or data science undergrads or doctoral students that have been working with us. So what we try and do is combine the epi thinking, if you will, and kind of what data should be shown together and why, with people who are really good at putting the data together and quickly generate interactive graphics and that sort of thing.
Cool. What a great composition. Unexpected. I wouldn't have thought that.
Yeah, it's a lot. I mean, this is all like a whole new world for me. It's been a lot of fun.
Well, I really
Despite the
appreciate your
circumstances.
time. I think this was really an enlightening talk. Very important work. I appreciate your work. On behalf of human health, we thank you. Tell your team we thank them. But we will let you go, and we appreciate your time.
Absolutely. Thanks so much. And thank you for the opportunity.
Absolutely. Take care.
Bye.